Good morning. My name is Tezila Oberbarnscheid. I'm an assistant professor of psychiatry at the University of Pittsburgh. I received my medical degree from Christian Alberts University in Germany and did my fourth year at Yale, proceeded with my psychiatry residency at Central Michigan University, and came to Pitt for the Addiction Psychiatry Fellowship and stayed on as faculty since. I currently work in a dual diagnosis outpatient setting, and I'm going to be talking today to you about anxiety disorders. I have no financial disclosures to share with you. The outline of the lecture, we're going to talk about the background of anxiety disorders. We're going to go over the DSM-5 criteria for anxiety disorders. We're going to be talking about diagnostic tests and possible questionnaires that you can be using with your patients, and then continue to dive into treatment of anxiety disorders. Anxiety disorders were described as early as Hippocrates, and there is a normal anxiety, which is actually a life-saving quality that humans are having to respond to a threatening situation and to prepare for defense as a fight-flight response. But then there's also the abnormal anxiety, which is the out-of-proportion response to a stimulus. That might be prolonged, it's out of control, and there's no actual threat. Many people who struggle with anxiety symptoms never seek any medical or psychiatric attention. And anxiety disorders are quite common. If we look here, 40 million people, about 18% of the adults in the United States struggle with anxiety disorders. So it's important to talk about it. Anxiety disorders are most common psychiatric disorders with a lifetime prevalence in the US of 32%. Anxiety disorders have a one-year prevalence about 14%. Anxiety can be so impairing that people are unable to work, they're unable to follow with their school, have absences, and also then create a larger cost burden. There might be disability claims. And it is actually the most common cause for disability in the US. According to the WHO, there are about 264 million people who suffer from anxiety disorder, and the trend has been increasing. And especially looking back at the last 2-3 years when we've been struggling with the COVID-19 pandemic, we know that throughout the pandemic, anxiety disorders in context of the enormous psychosocial stressors that people were facing has seen a peak as well. There has been a change in terms of the diagnostic classification and criteria for anxiety disorders from the DSM-4 going into the DSM-5. In previous DSMs, post-traumatic stress disorders and also obsessive compulsive disorders were also in the anxiety disorder category. However, now they have separate categories. They're classified as the trauma and stressor-related disorders and obsessive compulsive and related disorders. So they got their own group. New to the anxiety disorders since the DSM-5 are selective mutism and also the separation anxiety disorders. And the agoraphobia was separated from the panic disorder and is now its own diagnostic criteria. How many people struggle in the US or worldwide with anxiety disorders? We see here specific phobias, 8 to 12% in the United States, followed by social anxiety disorders. with 7%, smaller percentages in the agoraphobia or panic disorders, but also larger amount here for the anxiety disorders with about 2.9% of the adults or 0.9% of the adolescents. We see more frequently in the children and adolescents the separation anxiety. So we're going to talk a little bit more about the anxiety now. What is the most common cause of anxieties and how, when does it start? So most frequently anxiety disorder present in the early stages in life. The average age onset is age 11. It is more common in females than in males with a ratio of 1.6 to 1. There's a high co-occurring incidence of other mood disorders or anxiety disorders, and also substance use disorders are really frequent. Some to self-treat potentially the psychiatric diagnosis. Most commonly seen are sedative use disorders and alcohol use disorders. So we're going to move forward and talk about specific diagnoses and forms of anxiety and start out with the generalized anxiety disorder. And this slide represents here the DSM-5 criteria for generalized anxiety disorder. Generalized anxiety disorder is characterized by excessive, uncontrolled, and irrational worry about everyday things. And those are out of proportion about the actual events. And the worry typically shifts in between concerns and rapidly impairs function. And to meet the criteria for the generalized anxiety, the symptoms should be present more days than not, at least 6 months, and also lead to an impairment in psychosocial functioning, work or school. The person finds it difficult to control the worry. And then other symptomatic criteria would be 3 or more of the following 6 symptoms within the last 6 months, which are restlessness, fatigue, difficulty concentrating, irritability, muscle tension, or sleep disturbances. And for every psychiatric diagnosis, another mental disorder must be excluded, and also other medical concerns that could present as this disorder must be excluded, or substance use disorders. The female to male ratio for generalized anxiety is about 2 to 1. So now we're going to go over the symptoms that are associated with generalized anxiety disorder. They are psychological symptoms, as they were also listed in the criteria, but here there's poor concentration, irritability, low mood, restlessness, sometimes obsessive thoughts. Depersonalization can happen, and fear of anticipation, which is important in the vicious cycle, which for the anxiety disorder. Then there are physical symptoms that might occur: difficulty swallowing, epigastric discomfort, chest tightness. People hyperventilate, might experience palpitations, feel like they have to urinate, and present with urgency or frequency. Throughout the nervous system and tensions, there can be tremors present, tinnitus, dizziness, and people don't sleep well usually. So insomnia is a really common symptom as well. The etiology about generalized anxiety disorders, there are several theories and factors. There's definitely a hereditary component, and generalized anxiety disorder is 5 times more prevalent in those with first-degree relatives with generalized anxiety disorders. Also, childhood upbringing plays an important role, parenting styles, and neurobiological mechanisms, altered levels of certain neurotransmitters, or for example, brain-derived neurotrophic factor or CIMP, Also, in patients with generalized anxiety disorder, the stimulation of the autonomic nervous system is prolonged. And there's the negative feedback from the pituitary axis with cortisol is reduced. Other precipitating factors for generalized anxiety would be relationship stressors, unemployment, financial stressors, physical illness, or exposure to natural disasters, and other stressful life events that feed into continuous experience of this disorder. We're going to now move on into panic disorders. And here again, some of the criteria for panic disorders. 9% of the adult population experienced at least one panic attack in their lifetime. And what makes the panic disorder a panic is they come out of the blue. And patients experience intense fear and anxiety. And those feelings are often unprovoked and spontaneous. And panic attacks, they are per diagnosis recurrent. And usually it's more than one attack that's been followed by another attack within the month. And people start to anticipate the next panic attacks, get concerned about them, and it's a cycle of the anticipation actually having the panic attack. As we talked about it in the generalized anxiety criteria, we need to exclude that the panic attacks are not caused by any medical disease. This could be, for example, hyperthyroidism, hypoglycemia, pheochromocytoma, pulmonary embolism, myocardial infarction. So if somebody presents with these symptoms, we have to make sure that this is not the case, and that there's no other medical condition present, mental disorder present. We're going to continue to talk about symptoms of panic disorders, and they can range from sweating, chest pain is very common, feeling they can't breathe, shortness of breath, hot and cold flashes. Sometimes neurological symptoms can occur, for example, numbness or tingling, feeling lightheaded, or feeling that they faint, or even fear of dying, because it's such a loss of control when people suffer a panic attack. In terms of the etiology, the heritability is estimated about 40% for the panic disorders. And biochemical factors that are altered are listed here: the yohimbine, the isoproterenol, serotonin receptors, and also GABA. And there's also a cognitive hypothesis where patients with panic disorder have often more fears concerning the physical symptoms. Next anxiety disorder to talk about are the phobias. So there are different kinds of phobias possible. They can be triggered by objects, for example, blood, that would be hemophobia, needles, trypanophobia, vomiting, certain animals, spiders, very common, arachnophobia, snakes, orphidiophobia, and all certain situations. The dentist, very big topic from a lot of patients, being in the dark, being in tight enclosed elements or surroundings, elevators, or airplanes, severe weather, storms, thunder can induce phobia. And they're an excessive fear when the person is exposed to one or more of the following. And the response is out of proportion to the danger. And the symptoms can persist quite beyond the exposed time. And the symptoms lead to significant distress and significant impairment in psychosocial functioning, personal, family, educational, or also occupational functioning. So separated from the phobias is now the agoraphobia. And agoraphobia is a Greek word, and it comes from marketplace. And the criteria for this diagnosis is a persistent for more than 6 months, fear or anxiety about 2 or more of the following situations. So it can either be public transportation, it can be open places, the marketplace is one, but also enclosed situations like a shop, a theater, being in a crowd, a concert, or being in a line. And sometimes it's even just being outside of the home. Between 5 and 12% of the population worldwide have specific phobias. In agoraphobia, fear must involve thoughts that the escape from a situation might be difficult. Additional symptoms that contribute to this diagnosis are that the same situations trigger or repeat that fear and anxiety, and that patients start to avoid certain situations or require extra companionship during these situations, and that the fear or anxiety is out of proportion to the actual threat. The fear and the avoidance of these situations cause significant distress and impairment, again, in social functioning. People might not be able to go to work because of it. Students or children might not be able to tolerate the classroom. So it's to an impairing level. We have to make sure, again, that there's no other mental disorder present, and also no substance use disorder. I'm going to talk here about the treatment of agoraphobia. So the main treatment for anxiety disorders are usually therapy. So it's either cognitive behavioral therapy or psychotherapy, but especially for the agoraphobia, it's important to also try exposure therapy. So usually when patients struggle with this condition, the agoraphobia is maintained by avoidance, which prevents the deconditioning through having these apprehensive thoughts and fears of fainting, or also anticipating social embarrassment. This prevents them from getting over this response. But with the exposure therapy, you would gradually, to a tolerated level, decondition the phobic response. Also, medication options can be added. For example, antidepressants, SSRIs or SNRIs, or also tricyclics. I'm gonna talk a little bit more about those medications when we are through our list of other anxiety disorders. Next anxiety disorder to talk about is the social anxiety disorder. So this anxiety disorder is mostly happening when people are exposed to specific social situations and they feel they're negatively judged, embarrassed, humiliated. Most popular situation, even amongst colleagues, is to give a talk, to be, on stage, or to give a presentation in classroom when there are students, or to be in a business meeting, those situations. But it can also be in more normal everyday situations, for example, entering a grocery store, depending on the severity of these diagnoses. Patients who struggle with social anxiety avoid these anxiety-producing situations because they know how they respond, and they know they're gonna get fearful and anxious. The response is out of proportion, and the anxiety response again prevents psychosocial function and then interferes with their daily functioning and daily function of living. And it's not better explained by any other medical condition or substance use disorder. Roughly 7% of American adults have social anxiety disorders, and more than 75% of people experience their first symptoms in their childhood or early teenage years. And children might present differently with anxiety disorders or social anxiety other than older teenagers or adults. More commonly, they have more somatic symptoms, presenting maybe with repetitive stomach ache, nausea, or headaches, very common. The cause of social anxiety is unknown. Possible theories or factors can be parenting styles or early childhood experiences. Patient might experience difficulties processing or retrieving information. They might have insomnia. And for kids, they might also present with disruptive behaviors in class, oppositional behaviors, and often have frequent mistakes. Patients with social anxiety often remember their mother being fearful in social situations, or frequently describe their parents as being overprotective. Now we're going to move on to talk about separation anxiety disorder. And again, to differentiate these anxiety disorders, it is important to look over the DSM-5 criteria and to memorize what symptoms do need to be present to meet the diagnosis and to meet the criteria. For the separation anxiety disorder, according to DSM-5, we need at least 3 of the following criteria that are printed here on the right. So recurrent distress when anticipating or experiencing separation from home, or separation from a major attachment figure. People or patients worry about losing their attachment figure, and they think some things might happen to them, that they get sick, that they get hurt, that a disaster will occur, or that even somebody is going to die when they leave them. Persistent or excessive worry about experiencing an untoward event, so being kidnapped, having an accident when separated, and they will be reluctant to leave. They will, kids might present with a tantrum when they were supposed to go to school or leave their mom or go to kindergarten, depending on the age. It will be difficult for patients then to sleep away from home or to go anywhere without this attachment figure. Patients might present with nightmares, also in nightmares involving the theme of separation. And there are a lot of physical symptoms reported, headaches, stomach aches, nausea, vomiting, when they are undergoing separation. For separation anxiety, for the criteria, the fear, anxiety, and avoidance is persistent, lasting at least 4 weeks in kids and adolescents, and typically 6 months or more in adults. Again, to meet the diagnosis, the symptoms have to cause a significant distress or impairment in psychosocial functioning, academic, occupational, or other areas of functioning. And we have to exclude any other mental or medical disorder. We're going to be talking now about selective mutism. So what is selective mutism? It's a consistent failure to speak in specific social situations where there's an expectation for speaking, for example, in school or in other situations. And the duration of this disturbance for the diagnostic criteria needs to be at least 1 month. And it cannot be made within the first months of school, which is a common situation where kids get used to the new school environment, new friends. So there just might be more anxiety provoking. It interferes with their educational or occupational achievements. And it's not attributable to lack of knowledge or lack of comfort with the language or the social situation that they're in. And the disturbance is not better explained by any other communication disorder. Selective mutism is rare. The percentages that I found for this disorder is 0.03 to 1%. For this particular disorder, there does not appear to be a sex or ethnicity difference. It is, however, more likely to occur in young children than adults. Usually, the onset for selective mutism begins before the age of 5 years, and it often comes to clinical attention when school age years begin and when there is this need of social interaction or performance tasks. The course of selective mutism is unclear, but most individuals will outgrow the symptoms. So this was now an overview over the anxiety disorders according to DSM-5. We're going to be talking now about available tests. The most important part is to diagnose anxiety disorders in our patients so we can refer to treatment. I'm listing here available tests for anxiety disorders, and those are also tests that can be done in primary care settings or when patients are, for example, in a waiting room. So because a lot of these patients are undetected and never get to see a psychiatrist or a therapist to address their symptoms. So this commonly used questionnaire is called GAD-7, and it addresses the most common symptoms of anxiety. So it asks, over the last 2 weeks, how often have you been bothered by which of the following problems? And then it lists being nervous, being on edge, not even being able to control, stop worrying too much, having difficulties relaxing, being restless, being irritable, and being afraid that something awful might happen. And then the patient is, depending on if they experience this not at all on several days or more than half of the days or nearly every day, they're going to checkbox the score. And then we can address, depending on the score, how severe the anxiety is. In addition, they're asked to provide the information if you checked any problems, how difficult have they made it for you to do your work, take care of things at home, or get along with other people, to kind of address this psychosocial impairment degree. In terms of scoring, 0 to 4 is minimal anxiety, 5 to 9 would be mild anxiety, 10 to 14 is moderate anxiety, and 15 to 21 would be severe anxiety symptoms. And it's an easy test. It will take just a couple of minutes. The patient can do it by themselves. So it's really a useful tool. The next questionnaire that I would like to share with you is the Anxiety Symptoms Questionnaire. This is a little bit of a longer questionnaire, but also addresses the symptoms that we talked about when we went over the criteria for the DSM-5 diagnosis. So patients are asked to write a number in terms of intensity or frequency for the provided and listed symptoms, depending on how often or how severe they experience the symptoms. So this test takes a little bit more time and might require some help for the patient. They asked about in the past week about anxiety, nervousness, worrying, irritability, difficulties with relaxation, sleep disturbances, problems with concentration or attention, difficulties with memory, and also, in addition, address physical symptoms. For example, shortness of breath or chest tightness, gastrointestinal symptoms, nausea, constipation, diarrhea, dizziness, lightheadedness, neurological symptoms, numbness, tingling, or excessive flushing or sweating. In addition, asked about feeling restless or anticipation of things. And again, how all these symptoms impair the psychosocial functioning. So this is a very helpful tool, and with this, we'll definitely be able to make a diagnosis, but also refer, most importantly, to treatment for the patient. Last test that I'm going to share with you is the Hamilton Anxiety Scale. This is also very easy for the patient to complete form. It lists the anxiety symptoms, so anxious mood, tension, fears, insomnia, intellectual problems, so concentration or memory. In addition, mood symptoms, lack of interest, pleasure, hobbies, early awakening, then somatic symptoms like tinnitus, cardiovascular symptoms, respiratory symptoms, some difficulties with gastrointestinal symptoms, nausea, vomiting, genitourinary symptoms, autonomic symptoms, dry mouth, sweatiness, or behaviors. And patients are supposed to check box if like 0 would be not present at all to 4 very severe, how they experience these symptoms. And so this test is the only one here that also has this overlap with mood symptoms, looking at the depressed mood features. So it's important to know about these tests and maybe consider printing them out. You can easily download the PDFs through Google or other sites and have them available for your patients to see, is there an anxiety disorder present? We're going to move forward and talk about treatment options. So per literature review, only 60 to 85% of patients with anxiety disorder respond to current biological and psychological treatments. So some patients will struggle lifelong with these anxiety disorders and have refractory courses. Sometimes misdiagnosing can be an issue, but also referring to treatment attendance and retention, and then also diagnosing comorbidities, medical causes, or substance use disorders. So since I'm working in a dual diagnosis clinic, most of our patients have anxiety and a co-occurring substance use disorder. So it's really important to address both. We're going to be talking now about medication options. So most commonly used are the SSRIs and SNRIs. So FDA approved for generalized anxiety disorders are the escitalopram, which is Lexapro, the paroxetine, which is Paxil, duloxetine, the Cymbalta and the venlafaxine or Effexor. And for the FDA approved for panic disorders are the fluoxetine, paroxetine, sertraline, and venlafaxine. However, other antidepressants can be used. They're so-called used off-labeled. It's a case-by-case decision which the antidepressant you're gonna select for the patients. Other factors to consider are, for example, the side effect profile. Weight gain is a major concern for several patients, but also sexual side effects with some of these medications are quite prevalent. Or there might be co-occurring medical problems that you might consider treating with medications as well. For example, if your patient has anxiety disorder, but also a chronic pain condition, then we know, for example, that the duloxetine is helpful with the pain perception as well, and at the same time treats the anxiety disorder. So that might be a win-win for this medication group. The recommended duration of treatment can vary. Common question that patients will ask you: how long am I gonna take this, doctor? Because a lot of patients are hesitant to start psychiatric medication. It's important to discuss the timeline and to set the expectations to utilize the medication as long as they're feeling the way they're feeling or struggling with the anxiety symptoms. There's limited evidence of adverse outcome with chronic use of SSRIs or SNRIs. Particular category here is pregnant women. So most antidepressants or SSRIs or SNRIs are pregnancy category C. And Zoloft is the most well-researched or most recommended antidepressant for the use in pregnancy. But it needs to be discussed with the patient whether they want to go down this route and take a medication or maybe solely engage in therapy to start with. Other antidepressants are the TCAs or tricyclic antidepressants. They are one of the first classes of medications for anxiety disorders. They were not so frequently used anymore because of their side effect profile, which includes weight gain, anticholinergic symptoms like dry mouth, sedation, urinary hesitancy or retention, and also cardiac arrhythmias are quite concerning. Also, there is a risk with tricyclics to overdose. So this is something in a patient with, co-occurring depression, chronic suicidal ideation to consider, or at minimum, limit the supply that the patient has available. However, tricyclic antidepressants can be very useful as well. For example, when patients have chronic pain conditions, tricyclics have shown to be helpful in chronic pain conditions, neuropathic pain or migraines, and they can also help if patients have insomnia, as some of them are sedating, for example, the amitriptyline or the doxepin in lower doses could be helpful to treat both. Clomipramine and imipramine are FDA approved for panic disorder. We're going to be talking now about buspirone, or trade name is Buspar. This medication is commonly used. Mechanism is not totally understood. It's thought to be a partial agonist on the serotonin 5-HT1A receptor and an antagonist at certain postsynaptic serotonin 5-HT1 receptors, and also weak dopamine D2 blocking actions without any antipsychotic effects. Also, it's not known to cause any extrapyramidal effects. However, it has some side effects, but is usually one of the well-tolerated medications. But you have to educate the patient about possible dizziness, headaches, or nausea, potential chest pain, or shortness of breath. Also, it can interact with other substances. So, for example, with alcohol or marijuana, that interaction might intensify the side effects. There is also a risk of interaction with other drugs as it interacts or inhibits CYP3A4. So this needs to be, other drug levels might need to be monitored when this medication is introduced. It is pregnancy rating B, so it can be used in pregnancy. It has a low risk of dependency and a low risk of overdoses. The dose ranges for these medications are usually 15 to 60 milligram daily, and it's usually split up in twice a day or 3 times a day dosing. It is really well absorbed orally. Gradual onset of this medication, so usually an effect can be seen 10 days up to 4 weeks. And the nice thing is it can be used as an adjunctive medication. So while the patient is started as an SSRI or SNRI, where we know that the effect is not going to be fully seen until 8 to 10 weeks of treatment. A Cochrane review of buspirone for generalized anxiety disorder found that it was superior to placebo, but had a smaller effect size in generalized anxiety disorder compared to benzodiazepines or other antidepressants. Also, buspirone was less efficacious than placebo in patients with panic disorder. Now we're going to talk about the use of benzodiazepine. They are a longstanding medication in the treatment of anxiety disorders and still one of the most widely prescribed ones. They act on GABA A, so they're an agonist on that receptor, but they are no longer considered a first-line monotherapy for panic disorder or other anxiety disorders. They can be given short term, and this needs to be underlined in a limited supply, because with benzodiazepine, we know that over time, patients will develop tolerance and dependence, and there is a risk to start a sedative use disorder. So it is recommended to not prescribe benzodiazepines longer than 4 weeks of durations and to provide very limited and short-term prescriptions to prevent that this is not happening. Especially in the elderly, it is associated with neurocognitive dysfunction, falls. Also, other groups where it's really cautious to use are children. In children, we know if the benzodiazepine is used that there is a chance to get paradoxical responses where the kids would, instead of getting sedated or tired or less anxious, act out and become combative. And another group where it is absolutely contraindicated would be pregnant women because of the risk of respiratory depression, bradycardia, and the transmission to the fetus, and also in breastfeeding moms to the newborn child. So that benzodiazepines, yes, they do have a role, but the take-home message is really avoid them by any means. If you decide to give a benzodiazepine, provide a short-term prescription, no long-term. Otherwise, you will run into a problem that you have to start a detox treatment and a taper plan, which can be really, really difficult to discontinue this medication. Most commonly nowadays, we are using as an as-needed medication dihistamine hydroxyzine or visceral Atarax. It's really well tolerated. It comes in capsules and tablets. It's well absorbed orally. You can give various doses from 10 milligrams to 300 milligrams. Usually we start out low. There is a risk of overdose in the worst case, but also other side effects. The main one is sedation, that patients say they feel they can't function at work. Usually I try to start then with the 10 milligram capsule or tablet and increase from there. Maybe prescribe a higher dose in the evening to also target possible insomnia symptoms. It is cautious to be used in the elderly because of the anticholinergic effects. That's why in patients with neurocognitive disorders, dementia or Alzheimer's disease, it can cause additional memory impairment or confusion, and it is associated with falls, especially in higher doses. The big plus with this medication is that there's, unlike with the benzodiazepines, no risk of tolerance, dependence, or a substance use disorder. Another medication that is used for anxiety disorders or panic disorders is propranolol. It's a beta-adrenergic antagonist, also known as a blood pressure medication. It is not approved by the FDA for any psychiatric indications, but it is something that's frequently used. Side effects can include a cough, chest pain, dizziness, potentially depression, visual abnormalities, headaches, nausea, fatigue. And with this medication, there is a risk of fatal overdose. However, there is lack of research for support for the use of propranolol in anxiety disorder. So we're gonna talk now about another medication group, the anticonvulsants. Some anticonvulsants have GABAergic properties. These include medications like pregabalin, which is the Lyrica, or gabapentin, which is Neurontin, lamotrigine, Lamictal, or topiramate, Topamax. However, there's scant research for this medication class in terms of its efficacy for anxiety disorder. The strongest use or evidence for the treatment of generalized anxiety disorders in the pregabalin. There are multiple randomized controlled clinical trials available supporting the superiority compared to placebo and showing comparable effects to benzodiazepines. Also, pregabalin has shown to have some potential efficacy in SAD, but only in higher doses, 450 to 650 milligrams. Gabapentin or Neurontin is a medication we frequently see off-label prescribed for anxiety disorders. However, there is a lack of research supporting the evidence of its use. Gabapentin has several side effects that are discouraging from its use as well: dry mouth, constipation, weight gain. And as an addiction psychiatrist, I see a strong risk of dependence. There is tolerance. People and patients will ask for increasing doses for these medications. And I've seen overdoses with this medication as well by itself or with other substances that it's used with. It's very popular among patients with opioid use disorder as well. So this medication for psychiatric indications needs to be really cautiously used, and I would not recommend it by any means as a first line for the treatment of anxiety disorders. Lamotrigine, another anticonvulsant, is thought to inhibit voltage-guided sodium channels and cause a decrease in glutamate release. It has shown some anxiolytic properties in preclinical studies, but there's very few studies available showing lamotrigine for the use of anxiety disorders. One small case series reported an improvement in symptoms in panic disorders with agoraphobia. There are no known randomized clinical trials available for carbamazepine or oxcarbazepine with the indication anxiety disorders. Most importantly, we should encourage non-pharmacological treatment modalities for anxiety disorders. And also, if we do decide to start a medication, to provide co-occurring psychoeducation, psychotherapy, and other modalities. Helpful tools for anxiety disorder treatment are relaxation techniques, and this will be different patient by patient. For some patients, regular exercise might be helpful, or journaling. We encourage to engage in hobbies or engaging in joyful activities. It also is very helpful to create a short-term or a long-term schedule to prepare for the next day, to socialize with friends, and to utilize other tools, for example, self-help books, web pages, or telephone-guided treatment. Nowadays, there are also a lot of apps available that patients can download on their smartphone and utilize to cope with their anxiety symptoms. Prognosis, without treatment, about 80% still have the disorder 3 years after the onset. With early intervention and treatment, we can prevent chronic courses. For generalized anxiety disorder, we know with the start of SSRIs, we can get responses as high as 60 to 70%, and with a 50% remission after 1 year. With placebo, the response rate is 30 to 50%, with a 23% remission rate. About 1/3 show a response rate with cognitive behavioral therapy alone when they have the diagnosis of generalized anxiety disorders. In panic disorders, we get equal response of 50 to 70% with the start of an SSRI or cognitive behavioral therapy alone. But we know with anxiety disorders, in a particular panic disorders, we know that both treatment modalities combined have the best outcome. For SAD, SSRI have a 15 to 35% response rate, and with cognitive behavioral therapy, psychodynamic therapy, we can get an up to 70% response rate and a 40% remission rate. Those are my references that I used to create the slides and this talk, and I thank you for your attention.